Welcome to the Westbrook Family Dental Podcast. Your comfort is our priority, and we're here to change how you feel about the dentist. Join us as we answer common questions and discuss modern, gentle dental care for your whole family. Let's start the conversation.
You're sitting there in the dentist chair, just staring up at that blinding clinical light.
Right, bracing yourself for the absolute worst.
Exactly. I mean, your mind is already conjuring images of pliers and, medieval torture devices. You just know it's going to hurt.
Oh, absolutely. But what if I told you that the real danger of a tooth extraction isn't the dentist's tools at all?
Wait, really? What is it then?
The actual threats to your recovery are things like the invisible physics of a vacuum inside your mouth. And this bizarre biological reality that losing a single tooth literally tells your skeleton to start dissolving itself.
Okay, wow. Dissolving your skeleton, that's intense.
Yeah, it's a profound shift in perspective, really, because we view extractions through this lens of primal fear, the anticipation of having a piece of your anatomy forcefully removed.
Right.
But the moment you look at the actual clinical mechanics of what is happening, it stops being a horror story. It actually becomes a masterclass in human biology, fluid dynamics, and biomechanics.
Okay, let's unpack this, because we are completely dismantling that primal fear today for you listening. And we've gathered a really fascinating stack of sources for this deep dive.
Yeah, some excellent material to go through.
Yeah, we have official government health advisories from South Australia, Western Australia, and Queensland, alongside operational insights from a modern dental clinic.
So we're getting the official guidelines and the practical boots-on-the-ground perspective.
Exactly. And our mission for this deep dive is to transform what feels like a chaotic, terrifying ordeal into a highly predictable biological process. We want to replace the myths with the actual clinical mechanics of what happens to your body. So let's start right in that chair.
Good place to start.
Because the sources make it abundantly clear that nobody's just rushing in with pliers. There's this whole strategic mapping phase first.
Right. Dentists are essentially treating your mouth like an archaeological site. I mean, before any physical intervention, they rely on x-rays to map out the hidden topography under your gums.
So they're not just looking at the one bad tooth.
Not at all. They're assessing the density of the surrounding alveolar bone. They're tracking the exact curvature of the roots. And this is crucial. They're pinpointing the pathways of major nerves and blood vessels.
Which makes sense. You wouldn't dig a hole without checking for gas lines first. And actually, the Queensland government source highlights a major divergence based on what that map reveals. They draw a really hard line between a standard simple extraction and a surgical extraction.
Yes, that's a very important distinction.
I always just assumed surgical meant the dentist had to, pull harder.
That's a common misconception, actually.
Yeah.
The distinction comes down to accessibility and tissue involvement.
Yeah.
So a standard extraction basically implies the tooth is fully erupted, visible above the gum line, and has roots that allow for a straightforward pass out.
Okay, so what triggers the surgical route then?
A surgical extraction happens when the biology just isn't cooperating. The tooth might be impacted under the gum, or the visible crown might be so heavily decayed that it would just shatter under pressure.
Oh, yikes.
Yeah, so in a surgical scenario, the dentist actually has to actively incise the gum tissue. And they might potentially drill away a small collar of the surrounding jawbone just to expose enough of the tooth structure to get a grip on it.
See, hearing that brings up the absolute core of everyone's fear, right? The pain. I mean, if they are cutting gums and removing bone, our brains instantly scream out in panic.
Of course they do. It sounds brutal.
But the clinic source insists the pain factor is entirely misunderstood.
It is. We really have to separate nociception, which is the neurological signal for sharp pain, from proprioception, which is your body's awareness of movement and pressure.
Okay, nociception versus proprioception. Break that down for us.
Sure. Modern local anesthetics completely block those nociceptors. And in many clinics today, they even apply a topical numbing gel to the tissue before the needle even touches you.
Oh, nice. So you don't even feel the pinch.
Exactly. It shuts down the nerve endings at the surface. By the time the anesthetic fully infiltrates the tissue, the pathway that carries sharp pain signals to your brain is temporarily severed.
So the sharp pain is blocked. But patients constantly report feeling something, and that sensation triggers panic. If it isn't pain, what is the mechanical reality of what you're feeling in the chair?
What you're feeling is mechanical leverage. I mean, teeth are not rigidly fused to your jawbone like a nail hammered into a piece of wood.
They aren't. I thought they were just stuck in the bone.
Nope, they are actually suspended in their sockets by this highly complex hammock of thousands of microscopic elastic fibers. It's called the periodontal ligament.
A hammock of microscopic fibers. That's wild.
Yeah. So when the dentist applies force, they aren't yanking. They are systematically applying firm, rocking pressure to stretch, tire out, and eventually sever those microscopic ligament fibers. You feel the intense pressure of your jawbone serving as the fulcrum for that leverage, right?
Right.
But the sharp pain is totally absent.
It's almost like gently wiggling a very tight shoe off a foot. You aren't ripping the shoe off. You're systematically expanding the leather and breaking the friction around the object until it simply slips out of the space.
That is a perfect analogy. And when that shoe finally slips off, you are left with an incredibly vulnerable environment.
Right, an empty socket.
Exactly. But before we get to the aftermath, the modern clinic provides one massive psychological safety net during this stretching process.
Oh, I loved this part of the source.
Right. You, the patient, remain in ultimate control. You are instructed to simply raise your left hand if you feel anything beyond pressure.
And it really is that simple.
It is. That hand gesture is an absolute kill switch for the procedure. The dentist will instantly stop and administer more anesthetic.
Just knowing you have that left-hand veto power, I mean, that changes the entire psychological dynamic in the chair. You aren't trapped.
Exactly. It lowers the anxiety significantly.
So, okay, the ligaments are tired out, the tooth slips out of the socket, the dentist's tools are packed away, but your medical journey is literally just beginning, right? Because you now have a localized trauma site in your mouth.
Yes. The immediate focus is a piece of sterile gauze and the first 30 minutes of recovery.
Right, the dentist always makes you bite down on that folded gauze pad before you leave.
Yes, and this isn't just to mop up the immediate bleeding. That firm, continuous pressure actually triggers the start of the coagulation cascade.
The coagulation cascade sounds dramatic.
It is. Platelets in your blood encounter the damaged tissue, they change their physical shape to become sticky, and they begin clumping together. They weave a complex three-dimensional mesh of fibrin proteins.
So we aren't just talking about a dried, crusty scab here. This blood clot is an active biological scaffold. It sounds like the absolute hero of the entire healing process.
Oh, it's the single most important mechanism in your recovery. That fibrin mesh serves as a custom-made biological bandage that completely seals the socket.
Protecting everything underneath.
Right. It physically shields the highly vulnerable raw bone and the exposed nerve endings from the chaotic, bacteria-rich environment of your mouth. It also acts as the foundational matrix where specialized cells called fibroblasts will eventually migrate to start rebuilding new gum tissue and bone.
Wow. Okay, and if that biological scaffold fails, we enter the territory of what every dental patient dreads: dry socket.
Yes. Alveolar osteitis, clinically speaking.
The Queensland guidelines mention that, and I've always been terrified of the term. But looking at the actual biology, it seems like a purely mechanical failure. What is literally happening if we get dry socket?
It's the catastrophic failure or premature loss of that fibrin blood clot. If the clot fails to form, or if it's mechanically dislodged before the gum tissue is healed over the gap, your alveolar bone is left completely bare.
So just exposed bone in your mouth?
Yes, exposed to the air you breathe, the food you chew, the oral flora. The nerve endings inside that bone become wildly inflamed.
How?
Yeah, it sends out a severe radiating pain that often shoots up the side of the face right into the ear. And it also leads to a distinctly foul odor and taste as debris accumulates in the empty socket.
Which perfectly explains why the post-operative rules from these health advisories are incredibly rigid. I mean, the sources agree. For the first 24 hours, you cannot aggressively rinse your mouth out.
No rinsing, right?
You cannot engage in physical activity or sports. You can't consume alcohol. And there is a massive red line drawn under smoking or vaping for a full 7 days.
Yes, smoking introduces a dual threat. First, the carbon monoxide and nicotine cause severe vasoconstriction.
Meaning they shrink the blood vessels.
Exactly. Shrinking the vessels and starving the trauma site of the oxygen and immune cells it desperately needs to heal. But equally dangerous is the physical act of inhalation.
Okay, I want to push on that mechanical danger because I think a lot of listeners assume they can just power through a recovery on the couch. Let's say I'm taking a sick day, right? I'm skipping the sports, skipping the cigarettes, but I want to soothe my mouth with a thick, freezing cold milkshake through a straw. It sounds like the perfect, harmless recovery food.
The milkshake itself is fine, but introducing a straw turns your mouth into a hazardous physics experiment. What's fascinating here is that drawing a thick liquid up a narrow tube requires a significant amount of intraoral negative pressure.
Okay.
You're essentially creating a localized vacuum inside your mouth.
And that vacuum is literally stronger than the biological glue holding the clot to my jawbone.
Exactly. The suction force easily overcomes the tensile strength of that fragile fibrin mesh. You can quite literally rip the protective scaffolding right out of its socket and swallow it without even realizing what you've done.
Oh my God. Until the dry socket pain hits hours later.
Precisely. So enjoy the cold milkshake because the temperature actually helps reduce inflammation, but you must use a spoon.
Okay, spoon only. We are respecting the fluid dynamics of the mouth. But managing the physical pain and swelling around that clot brings up a really fascinating conflict in the sources.
Yes, it certainly does.
Because swelling is inevitable, especially after those surgical extractions we discussed earlier. The Western Australian source maps this out clearly. The facial swelling and bruising will generally peak around 36 to 48 hours after surgery before naturally subsiding.
Swelling is simply the visible result of your body's inflammatory cascade. Blood vessels in the area undergo vasodilation, they widen, to allow a massive influx of fluid, white blood cells, and healing factors to flood the trauma site.
Right, and to manage the physical discomfort of all that pressure, the universal physical remedies apply. Sleep with your head elevated on 2 pillows to reduce the local blood pressure and throbbing.
Apply an ice pack to your cheek for 20 minutes on, 10 minutes off. The cold induces vasoconstriction, physically shrinking those blood vessels to stem the excessive fluid buildup.
And the South Australian guidelines also introduce warm saltwater rinses starting the day after the extraction. Half a teaspoon of salt in warm water, gently bathed over the area after meals. But when we look at the official recommendations for actual painkiller medications, we run into a massive, glaring contradiction between the government sources.
It is a very striking divergence in public health advice.
Yeah. I mean, the South Australian guidelines, backed by the modern dental clinic's advice, explicitly state that it is fine to take an anti-inflammatory like ibuprofen, such as Nurofen, to stay ahead of the pain before the local anesthetic wears off.
Right.
But when you read the Western Australian Health Service document, they issue the exact opposite instruction. They explicitly warn patients against taking aspirin or ibuprofen, stating it may lead to further bleeding, and they direct patients to stick solely to paracetamol.
How do two major health authorities land on completely opposite sides of a basic painkiller?
Well, if we connect this to the bigger picture, we have to look at the underlying pharmacology of a drug like ibuprofen to understand this split.
Okay.
Ibuprofen belongs to a class of drugs known as NSAIDs, non-steroidal anti-inflammatory drugs. They work by inhibiting specific enzymes in your body called COX enzymes, or cyclooxygenase.
So these enzymes are basically the molecular alarm bells that tell the body to swell up and hurt. Broadly, yes. But there are two main types of this enzyme. COX2 is primarily responsible for triggering the inflammation and pain at the trauma site. By blocking COX2, ibuprofen excellently shuts down the swelling and the ache.
Right, which is exactly what you want when your face is throbbing.
Exactly. And that is the biological rationale driving the South Australian guidelines. They are prioritizing aggressive inflammation control to keep the patient comfortable.
But ibuprofen isn't a precision strike, right? It's kind of a blunt instrument. It blocks both enzymes. So what is COX1 doing that makes Western Australia so nervous?
That's the catch.
Yeah.
COX1 is responsible for producing a chemical called thromboxane A2. And this chemical is the exact signal that tells your blood platelets to become sticky and clump together.
Oh, so by taking ibuprofen, you inadvertently muffle the signal that builds your hero blood clot.
Exactly.
So South Australia is prioritizing shutting down the swelling, while Western Australia is fiercely guarding the formation of the blood clot at the expense of anti-inflammatory relief.
Yes. Neither is inherently wrong, but they are prioritizing entirely different biological risks.
And this highlights why generic guidelines can be dangerous. Your personal medical history dictates which biological risk is more relevant to you, right?
Absolutely. If you have a history of severe bleeding disorders or gastric ulcers, the Western Australian approach is much safer. If you are a healthy individual facing severe postoperative swelling, the South Australian approach might be appropriate.
The takeaway here is that you must consult your specific GP, pharmacist, or treating dentist rather than guessing.
Tailored pharmacology over internet guesswork, always.
Always. Okay, so now let's look past those initial weeks. The gums eventually heal over, the acute pain is gone. Patients usually assume they are entirely out of the woods, But removing a tooth actually alters the physics of your jaw. It triggers a hidden, long-term domino effect.
It really does. And this is the phase most patients completely ignore because the immediate threat has passed. We tend to view our teeth as individual, independent units, like keys on a piano. But mechanically, your dental arch is a highly integrated, interdependent structural system.
I hear this listener assumption all the time, actually. People will say, the tooth they pulled is way in the back of my mouth. Nobody can see the gap when I smile, so I'm not going to spend the money on an implant or a bridge. I'll just live with it.
Yeah, that aesthetic justification completely ignores the structural reality. Your teeth, quite literally, hold each other in place through mutual continuous contact.
Okay.
When you leave a gap in that arch, the neighboring teeth lose their lateral support. Over time, subjected to the constant forces of chewing and speaking, those neighboring teeth will slowly begin to drift, tilt, and collapse into the empty space.
I always visualize the lower jaw like a tightly packed bookshelf. If you pull a heavy 800-page book out from the middle of the shelf, the books next to it don't stay standing perfectly upright.
No, they don't.
Gravity and lateral pressure take over, and eventually the surrounding books inevitably slump and slide sideways into the newly created void.
That's exactly it. And as those teeth slump sideways, your entire bite alignment shifts. The upper tooth that used to bite against the missing bottom tooth may also begin to over-erupt, growing down into the gap because it no longer has an opposing force stopping it.
Oh, wow. So it just keeps growing down.
Essentially, yes. But the shifting teeth are only half of the long-term consequence. The jawbone itself physically reacts to the missing tooth in a much more alarming way. It begins to dissolve.
Wait, the actual bone of the jaw shrinks. How does your skeleton even know a tooth is missing?
It's governed by a principle in biomechanics known as Wolff's Law.
Wolff's Law?
Yes, which states that bone in a healthy person will adapt to the loads under which it is placed. Your jawbone maintains its density and mass purely because of the mechanical action of chewing. Every single time you bite down, the root of the tooth sends microstrains, tiny mechanical stress signals into the surrounding alveolar bone.
So chewing is essentially weightlifting for your jaw.
Yes. Those stress signals stimulate specialized cells called osteoblasts, which constantly lay down new bone tissue. But bone remodeling is a two-way street. You also have cells called osteoclasts, which act as a demolition crew.
A demolition crew?
Right, breaking down old bones so the calcium can be used elsewhere in the body. When you extract the tooth, the mechanical loading stops entirely.
Ah, so the osteoblasts go to sleep because there's no stress, but the demolition crew keeps working.
Precisely. The body is relentlessly efficient. It registers that the bone in that specific area is no longer being utilized for mechanical work, so it stops sending resources to maintain it. Over time, the osteoclasts resorb the bone, and the jaw ridge literally shrinks away in height and width.
Which means if you wait, say, 5 or 10 years and finally decide you do want a dental implant to fill the gap, your dentist is going to look at the x-ray and realize there isn't enough bone mass left to securely anchor a titanium screw. You've essentially locked yourself out of an easy fix.
Exactly. You would then require invasive, expensive bone grafting procedures to rebuild the foundation before an implant could even be considered.
Wow.
And, while we are discussing the gravity of these procedures, the Queensland Advisory specifically notes a few rare but serious long-term risks associated with the extraction itself. Depending on the proximity of the tooth roots to the inferior alveolar nerve, the extraction process can sometimes irritate or bruise that nerve bundle.
Resulting in what? Permanent numbness?
It can cause prolonged or very rarely permanent paresthesia, which is a numbness, tingling, or altered sensation in the lower lip, tongue, cheek, or chin. And just to be entirely transparent with the clinical data, the Queensland document states that in extremely rare circumstances, death can be a result of the procedure or its complications.
Wait, death? Really?
It's usually related to severe systemic infections or extreme anesthetic reactions. It is incredibly uncommon, but it really underscores that an extraction is a genuine surgical intervention.
Yeah, it isn't a haircut, it's a significant medical event. Which really drives home the ultimate point of this whole deep dive. Early intervention is always your best defense. If you let the primal fear of the dentist's chair paralyze you, a tooth that could have been saved with a simple, localized treatment will eventually decay to the point where extraction is the only mathematical option left.
Delaying treatment out of fear guarantees a more invasive outcome.
Right. So to pull all of these biological threads together for you, hearing that a tooth needs to come out naturally makes your stomach drop, but the clinical reality is a marvel of controlled biology. The dentist is just systematically tiring out microscopic ligaments until the tooth slips free. The sharp pain is chemically blocked. You are just feeling leverage.
Yes, and the true heavy lifting of the recovery is performed by your own blood.
Exactly. Forming that complex fibrin scaffold to shield your skeleton, protect that clot from the vacuum of a straw, navigate the painkiller debate carefully with your doctor, and respect the structural integrity of your jaw by addressing the gap.
And looking at the mechanics of bone loss leaves us with a truly fascinating concept to ponder. We just explored how a section of your jawbone will literally dissolve and be reabsorbed by the body if it loses the mechanical stimulation of a single chewing tooth.
Right, that use it or lose it phenomenon driven by Wolff's Law.
Yes, it raises a compelling question about the entirety of the human system. What other bones or biological systems in our bodies are secretly relying on constant hidden mechanical stress just to maintain their basic mass and structure?
Ooh, that's a great point. And if our modern diets are becoming, generationally softer, requiring less and less occlusal force to chew, are our very skulls and jaws slowly shrinking over a lifetime simply because we aren't signaling our skeleton to stay strong?
It is a profound reminder that our anatomy is deeply responsive to our environment.
Your body is a deeply interconnected, highly adaptable machine, constantly remodeling itself based on exactly what you ask or fail to ask it to do. So the next time you find yourself leaning back in that chair, staring up into the bright light, remember, you aren't a victim of a medieval procedure. You are the architect of a highly predictable biological cascade. Thank you for joining us on this deep dive, and as always, keep questioning the physics of the world around you.